I'm going to sort of switch and try to give you two use cases of work that we've been doing over the years. So this is work that I did in conjunction with Jeremiah Brown and Richard Solomon that was funded by NIDDK but done in the VA. And essentially, this is a culmination of 15 years of work that started with my VA CDA, went through VA IIR, which is like an R01, and then ended up in this implementation trial. And so if you look at patients that undergo cardiac catheterization, one of the primary risks that they face, beyond all the cardiovascular complications, is they come in frequently in a dehydrated state from a variety of different reasons, and they get contrast, which is a dye that's used to essentially allow you to use imaging to see the actual arteries in the heart and to see where the blockages are so that you can potentially intervene in them. And if you look at it, the contrast, the dehydration, medications that are used, all of those create sort of a cocktail environment that can damage the kidneys directly after this procedure. And so this is a graph, an overview of risk of actual morbidity and mortality associated with that. So if you look at this, there's about 1.2 million of these a year. About 10 to 15% of cases have acute kidney injury, and the risk of mortality and other adverse events goes way up when you get this type of injury. And there's a lot of trial data, some small sample, some observational, some larger, that shows that reducing certain characteristics in the contrast helps, reducing the amount of contrast helps, really being aggressive about making sure people get hydrated before, either stopping medicines that dehydrate them or asking them to drink a lot of water, or even doing IV fluids beforehand can help protect their kidneys. It goes without saying that if you don't measure the kidney function before and after, you don't know whether you've damaged the kidneys, so that's important. And other medication optimization is important too, stopping certain medications and preventing these risks. And so we looked in the VA actually in preparation, one of the things for the trial, and this is risk adjusted, so it's risk adjusted on a host of patient factors. It's risk adjusted on provider, it's risk adjusted on site factors. And you can see the clinical variation in the rates of post-procedural acute kidney injury after cardiac catheterization vary quite highly. The ones in red are at a significantly higher risk of the adverse event, and the ones in green are actually significantly lower. So the question is, wow, that's what's going on there? That's a lot of variation. Maybe there's something we could do about that. And so, you know, while there was a fair indication of some of the benefits that could be implemented, when we did a survey of cath lab directors and we did some interview work, it turns out that the actual implementation practice in these cardiac cath labs in the VA were highly variable. Some had no protocols for any hydration or any contrast management. Some had a lot. And so that variability, we think, was contributing to that process. And so if you look in the literature around leveraging tools to help standardized clinical care practice, implementation science is one of the ways in which you do this. But in this area, there was actually a relative lack of publication in that area. And so we sought to develop an integrated approach where Jeremiah Brown at Dartmouth led an intensive quality improvement coaching that I'll go into a little bit. And then our team in Nashville developed an information synthesis dashboard, a machine learning risk adjustment model, and a signal detection pathway to basically provide information to the cath lab teams to do this work. And our goal really was to integrate both quality improvement coaching to help change provider behavior and informatics at the sort of clinical unit level instead of the individual patient level. So we had a 20-site cluster randomized trial. Essentially, we were looking at two different interventions, the quality improvement intervention and the informatics intervention. And so we had equal number of sites randomized to each of the 4 blocks, neither one of or both. And we did an 18-month active period, and then we did sort of a post-sustainability period. And we basically were taking all adult patients who went into the cath lab, and we were excluding people on dialysis, which is when their kidneys were already not functioning, really looking at a accepted definition of acute kidney injury, which was a 0.3 milligram per deciliter increase or a 50% relative increase of their creatinine as a proxy for renal function. And so Jeremiah had really done over a decade of work in sort of iterative quality improvement coaching. So there was a protocol in which we didn't actually do a formal clinical trial. We didn't dictate, hey, you have to do this contrast reduction, hey, you have to do this hydration. We basically just said, you know, we know that you have your own sort of drivers for your clinical enterprise, so we're going to coach you on all the different things that you can do. We're going to tell you how you can do it. And each one of the groups of the sites actually got into a community of practice where we would have monthly sessions where they would all talk to each other about their experiences as well, and we would help facilitate that. And so that was one arm of the intervention. And then the other intervention was the work that we did where we built a machine learning risk adjustment model, we implemented it in the system, and we built a user interface dashboard that let each site log in and basically see how they were doing relative to their peers, both at a national and regional level, looking at their performance. We showed, there was in the bottom left, there was basically a visualization that let them see all of their cases, all the risk factors associated with the machine learning model. And we chose to use one that was relatively intuitive where the clinicians could see the weights of the risk model rather than a more advanced one. And we essentially allowed them to see where they were measuring creatinine, where they weren't, and they used this information for the arm that had it in helping inform their decision about changes to their system. And so some of the early work that we did as part of my career development award that then became the first IIR was we built a national risk prediction model using a really old technology, LASSO, which is now sort of not really, doesn't account for nonlinearity, doesn't account for interaction terms unless you explicitly model it, but still had a pretty good performance. And when we tested the more advanced machine learning models later, they didn't really perform a lot better. So we ended up using a very simple, intuitive model. And you can see that the event rates here are sort of in the 12 to 13% range for the outcome. If you look at the external validation that another group did in Greece of our model, you can see here that for a liberal definition, we were doing quite poorly, so it did not externally validate. And then for a really strict version, we were one of the better models. Regardless, what this showed, though, was that the performance in another environment degraded. And I guess one of the comments I would make, sort of a meta comment, is historically, risk models were more acceptable if they were externally validated. And I really think the paradigm is shifting because we know models are going to degrade. We know they're going to change over time. So external validation is useful in terms of helping to assess for initial overfitting, but really doesn't obviate the need to do continued site-level monitoring of these algorithms. So we had a lot of challenges in sort of maintaining the risk adjustment mathematics underneath the data visualization. So the electronic health record data was changing, as I mentioned. There was basically data variation between sites that we had to surveil and account for. We had to actually convert from a retrospective warehouse data to a clinical production real-time EHR data. And then there was data drift over time. So we started the intervention 6 months before the pandemic hit in March of 2020. And so we knew all of the above things, and so we had a plan for how we were going to do that, and I'm going to show that in a minute. But had we not had a plan for monitoring and surveilling and updating our model, our trial would have been killed. So, so it was fortuitous, but I will show you sort of how we were able to survive through that process. So Sharon Davis, as the final part of her PhD work before she joined our center as faculty, built a sort of a machine learning-based predictive analytics surveillance system that essentially sits on top of models. You deploy it in the system. It basically uses statistical process control and signal detection techniques to look at the model, compare it as it's doing over time, each week, each month. And if the model starts drifting through a variety of criteria, then it actually can detect that, send the model to basically an updating module where it dynamically updates the module and the model back into performance relative to the continually accruing data, and then deploy that model back into production. So essentially, we implemented this proactively because we knew that there were going to be data drifts, and it turns out that this was critical when the pandemic hit, because cath labs shut down for all elective procedures for, I think, 3 to 6 months. Our volume of cases just took a nosedive, and the whole data shifts, all of the coefficients, all of the modeling system completely changed and was dynamically, iteratively updated during this period. We would not have been able to do that without this system. And so this is just data actually showing right before the pandemic of how we were proving that we could maintain the model performance. I won't go into details of the mathematics, but the system was working before, and then we were continuing to surveil it after the pandemic, and it continued to maintain the performance. So this is the money slide. So why we spent 15 years doing this work. So after we implemented this in 20 sites, we worked with the cath for 18 months, and we evaluated the intervention, which was the quality improvement coaching and the informatics dashboard together and separately. We had a combined 46% reduction, risk adjusted, among the sites that it had access to both the quality improvement coaching and the intervention, which is the strongest reduction in AKI that has been reported for cardiac catheterization. Even more happy news is that we basically shut everything down, let them keep the dashboard and watch them for a year, but had no contact with anyone. And the intervention was sustained for a full year after the active intervention. Well, I can't show that data here, but it'll be presented later at the National Nephrology Conference. And so none of that would have been possible, though. So changing clinician behavior is hard. And so none of that would have been possible without tight coupling, both at the national level with basically the cath lab leadership at a national level, and then working with each site's cath lab manager, cath lab director, getting buy-in from them to actually implement their change. I actually think one of the differentiators in this work was that we allowed them to do whatever it is that they wanted to do. We showed them the information, and then they chose what was best for them. And the fact that it was still a heterogeneous intervention, but still had that level of impact, supports that sort of process can be used in the future. I don't think the informatics intervention by itself, even though it did show an impact each individual, would really strongly change provider behavior. Some of the work we've done over the years shows that without something active coupled with passive informatics capacity results in sort of a watering down or a mitigation of the possible effect. So it's important to have both active and passive elements. And again, I would just say that the 46% reduction was a very welcome result. So so that tells you one story, which is at the population level, really trying to get the target were the providers, but we didn't intervene in a direct patient framework. This is work that was led by Salim Virani, funded by the VA, and was recently completed, which seeks to also partner informatics to help, but it's more of a direct patient. So we were looking at patients in the VA that basically, as you saw before, that variation of folks with heart disease that do or don't get statins. We partnered with his team in cardiology to essentially help design clinical decision support to help improve prescribing of cholesterol medicine, statins, for people with known heart disease. And so if you look at the sort of the state of the literature, pretty much statins are strongly protective for heart attacks and cardiovascular disease. It's well known, it's well established, lots of randomized clinical trials. But if you look at why they're not prescribed, some of the key drivers are here. There's therapeutic clinical inertia, there's patient preference. There's actually a lot of statin side effects, muscle aches predominantly, although fatigue and other things. And those have been picked up in the press. And in fact, in some cases, there's been a lot of discussion around over-reporting of symptoms, or patients being very symptom sensitive to the sensation of that they might be getting muscle aches because of a lot of the press and popular discussions around these, which actually challenges providers then to maintain these strongly protected medications in clinical environments. And so what we're trying to do with this study is we really wanted to try to use natural language processing, use informatics, use data science to build a very contextual system where we could give to providers all of the history and all of the care around the statins and the side effects in order to let them quickly review it and make a decision with the patients where they didn't have to do a chart review across years and years worth of data. And so, as I mentioned, the sort of life cycle of AI implementation and ML implementation, first thing you have to do is you have to make sure that you have the right target, that you are doing what the clinicians want, that you're doing what the patients want. And so this was work that Salim and Dr. Ahmed led, where they basically interviewed people at the Nashville VA and at the Houston VA, looking at, what did the patients want? What did the providers want? What would make them change their prescribing practice? And we sort of, using qualitative assessments, we looked at 21 different patients, 20 different providers, standard qualitative assessment with interviews and transcribing and sort of convergence on themes. And then we used that when we were designing basically the informatics intervention downstream that I'll mention in a moment. The other problem is that a lot of these side effects are listed, but they're not coded. So you have a code for heart disease, you have a code for diabetes, you don't have a code for muscle, well, you have a code for muscle aches, but providers very much undercode that. So you'll have a patient that'll come in, they'll say, hey doc, I don't want to take the statin anymore, I'm stopping it. The provider will note that in their note, but they won't actually put myalgias as a structured code when they close the outpatient encounter. So there's no way to effectively get at that. And so Alexander Turchin at Brigham and Women's Hospital and Glenn Gauble, who's in our center at Vanderbilt, sort of together adapted a program called Canary to essentially look in the electronic health record, look for medication, look for statins, detect adverse events, detect reasons not on medications, and basically extracted that information into a structured data stream that could be used for this purpose. The really interesting thing here is it was really, so it's important when you do NLP that, I've had instances in my career where we think we're going to really make an impact with natural language processing. We spend $500,000, we build a cool tool, and then we integrate that data with the structured data, and it doesn't help. Basically has no gain for the information content. So it's really important when you do this type of work, if you're going to go through the cost of implementing that in a production system, you make sure that it's going to make a difference. And so the AUC here is essentially proof that it made a very substantial difference to add that information into the system. And so we basically used this formative work and designed a trial where we were building an algorithm to help us with clinical summaries. And our goal was to really minimize provider burden and maximize workflow integration. And I'll show you in a moment how we tried to do that. So we basically took 27 primary care clinics in the Houston VA and the Nashville VA. We randomized them to either get the intervention or usual care. These were adults with known cardiovascular disease by administrative codes, and we excluded patients basically that didn't have a primary care doctor, either hadn't been seen in 2 years or weren't on a primary care doctor's panel. And we had 13 clinics. You can see we had about 117 clinicians in one arm, and we had 128 in the other. And essentially the intervention arm, which I'll talk about in a minute, got basically a context-aware clinical summary, and the usual care did not. And so our primary outcome in this case is we really wanted people to be on the cholesterol-reducing medication, to be on the statin, since it's known to be improved. Now, you can't get to 100% because not everyone's going to be able to tolerate them, but the goal was to improve prescribing practice. And the secondary analysis was, so high-intensity statin is a specific subset of medication dosage and medications, whereas the secondary one was just, did they get on any statin, even if it wasn't guideline recommended? And so first, we developed centrally processed clinical patient-aware care summaries that I'll go into in a moment. And we sent those to the patients in the intervention arm into the electronic health record, and we incorporated the natural language processing algorithms as well as structured data in order to do that. We sent reminders out, and we attempted to prioritize synchronous reminders, which essentially are reminders that go to providers and patients about 2 to 7 days before a known patient encounter in order to really try to optimize, and that's what providers were wanting. They were like, if you give this to me in the middle of, without context, where I'm dealing with my patients every day and it's 3 months till I see the patient, this is gonna annoy me. But if you give this to me the day before I see the patient, then this is pretty useful. And so we tried to emphasize that sort of synchronous delivery system. we actually went through multiple iterations where the providers were like, we need more information. Why are you making me go find this? You know, why are you triggering this? What's their history of medication use? What side effects have they had? You know, what different things have they tried? And so we actually incorporated all of those things into a care summary and provided that to them in the electronic health record. To reduce, this was something we tried, so there was a lot of concern on the clinical leadership at both facilities that essentially there are already rule-based clinical reminders in practice. We're going to get, you know, this is going to really cause a lot of angst, and so we actually implemented a sub-algorithm that if once someone got 3 alerts, until they acknowledged those alerts, they didn't get any more. So if they chose not to acknowledge them, they didn't get piled up 30 alerts, which would just make, and I'm a primary care physician in the VA, that would make me angry because we have to get through our alerts every week as part of our regular clinical care. And so I really think that this was one of the critical components to sort of helping manage provider acceptance. They could opt out of the study anytime they wanted to, and then usual care is just regular access to the system, to the provider systems that the VA has. So I'm not going to go into detail here. I will stay here a few minutes so you can kind of look over. This is an example document that's anonymized of sort of some of the information that's provided, and obviously the notes and the material are from the natural language processing, and there's a lot more granularity that's usually there for a real patient, but it gives you sort of why someone was triggered, what were all the notes in which statins were mentioned, what side effects were mentioned, what was their history of prescribing. And then this was basically delivered in real time into the production clinical EHR at the 2 sites in the VA. And so this is a technical workflow of how we had to do it. We basically used data warehouse data and data warehouse information, which was updated nightly. The NLP algorithm ran. We brought that into a work monitor and a notification service that then had an interface with the electronic health record that delivered the information into the patient's chart and tagged the provider to review it. So the usual care arm had all of these things. So the VA actually is really active in primary care and dashboards and trying to provide this information, but it's all passive. And so as a primary care doc, I could get to all of this, but it's up to us to access it when we want to. And so we randomized about 18,400 patients to intervention and about 18,200 to the control, and then we ran through the process. So about 42% actually had NLP and structured evidence of adverse events, which was pretty high. And then the other thing that was really interesting to note is because we limited the throughput of the algorithm to prevent alert fatigue, we didn't get to everybody in the intervention arm. So we had to analyze this basically on an intention to treat using a standardized trial design, but we only actually got alerts to 53% of the patients. And we really were trying for synchronous alerts. That was our priority. We always did that. But if you look, even when we tried, we still only got synchronous alerts a quarter of the time, which I think contributed to alert fatigue for the providers, as we knew it would, and we tried to avoid it where we could. And I think this is a good cautionary tale that even when we engage providers and what they want, we tried to build context-aware systems in the way that they want, and we tried to interject it in the workflow as best we could within technical and sort of other limitations. We still had a dropout rate of approximately 30% of the providers during the course of the trial, which lets you know how busy primary care docs are and lets you know how really tightly you have to couple workflow and context systems to really meet them where they need the information rather than where you think they need the information. And I think we could do a better job there. So the provider dropout, again, I think the 2 main issues, the point of something like this is to show some of the warts, not just the successes. We had a data lag. So we had a 2 to 3 lag from the time we analyzed the data to the time we generated the real-time alert. Epic and Cerner pieces have more real-time integration, so I think that could be eliminated for some systems. And I think there was also insufficient primary care alignment. So I was in a bit of an interesting situation. So the the clinical subject matter expert for this was a lipid specialist cardiologist. From a primary care perspective, I was advocating, and he was actually on the national guideline committee for this work, and I was like, from a primary care standpoint, if I refer somebody to lipid clinic, I'm done. Like, I've done everything I can. I'm referring them on. Or there's a new injected medicine that's now being used if people don't tolerate statins. And I was like, well, if we get them on that, then shouldn't that count? Because if they're already on that, and I've already tried statins, I don't want this alert. But because these hadn't been incorporated into the guidelines officially, the decision was made to stick to the guideline expression, and I think this directly contributed to primary care frustration. And so one of the interesting things we found was because this trial also was going on during the pandemic and in the time period afterwards, the actual prescribing rate declined in the non-intervention arm. So when we found the impact that we found was that we improved prescribing in the intervention arm some, but we also, the non-intervention arm decayed quite a bit. And so the odds ratio showed a significant impact for the use of the clinical summary tool in the intervention, and between groups was about 3.8%. And so I think the real take home here is this. So remember, we only got the alerts to about half of the people in the intervention trial. And so if you really took a look at and broke it down into control that did and didn't, and intervention that did and didn't get the intervention, among those that actually got the intervention, you only needed to send 10 reminders to get a statin prescription. Which shows a pretty significant effect of that care summary on clinician decision-making process. And so this is also sort of another analysis that really shows if you're trying to look at how effective were these reminders, as you would expect, if you give it to the provider right before they see a patient, it's more effective. If you give it to patients that don't already have documented side effects from prior statins, it's more effective, which is in alignment with what we were anticipating. And then for secondary outcomes, really looking at any statin, I think what we saw interestingly during the trial is that essentially there was a decline in statin prescribing, and so in some respects, the intervention prevented a decline. And so for this trial, I think the main take-homes are, I think there's a whole body of work around a simple sort of rule-based clinical reminder, like you need a flu shot, did you get a flu shot? And then I think there's a lot of newer research going on about building a predictive model for the likelihood of needing a clinical reminder, setting a threshold, and then still triggering a very direct alert for, hey, you need this. I think there's also an opportunity space to build sort of a workflow support where you know what the cognitive process is for a provider in sort of making some decision making, and then in partnership with the patient discussing that and then making the decision together. And one of the ways you can reduce provider burnout and reduce cognitive burden is by basically providing all of that information in a nice sort of single summary point for them to review. And I think there's a lot more work that could be done in that area. I would just also say that we halted a temporal decrease, and that there were only 10 reminders that needed to be sent in order to have an impact in a patient prescribing. Even that being said, I think we really could do a better job. I think we could have done a better job in the timing of the alerts. I think we could have done a better job in excluding some alerts to make the providers even happier that when they got one, it was a real one and they needed to attend to it. And I think there's opportunities to improve there. And so lastly, I'm hoping that these two use cases sort of gave you a flavor for how we're trying to use AI and ML to really sort of go from observational data into a translation into information, into some sort of user interface or workflow in partnership with the end users to actually impact clinical care. It's challenging. In fact, sometimes I feel like the machine learning and the crunchy fun stuff for me are the easiest parts of what you do, and all of the human-computer interaction and implementation science and changing provider behavior are the hard parts. That's why I partner with Jeremiah Brown and Salim Varani and others who really help us move that forward. And so I just will end the slide with, this is the center team that I work with at Vanderbilt that helps make it all possible for us. And I'm happy to answer questions.
Hey, Michael, great, amazing, congratulations, fantastic. This is work that really changes care, improves outcomes. 2 questions. You mentioned sort of the patient's fear of statins, potentially. I've seen that as well. And are there things we could do, tools we could use to help with that? Second, you know, there's risk calculators like on my mobile phone. So there's probably some people in your control group using those, don't know how many, but do we need to understand how well that's working, or does it just not matter because your thing is actually like way improving all those people together?
Yeah, so I'll take the second question, I think, first, which is, you know, the risk calculator. It's funny, the history of risk calculators themselves are really interesting. You know, the earliest ones were sort of the ones you did manually for heart disease and some other sort of ER risk factors. And I think those are still useful. I think the problem with them is that increasingly we know that they go out of performance, right? So the literature shows that some of those heart disease risk factors, you know, for patient subpopulations, they can be biased, and, you know, you go 2 or 3 years out from when they're developed and they start to sort of not really represent patient populations. So I don't know, I would say even for those risk calculators, I think there's an opportunity to couple repeated modeling updates for those algorithms to more accurately reflect downstream risk. And I don't think that this tool like replaces those. I think this tool is an example of a family of spectrum of activities, from a simple risk calculator for heart disease, or do you need an ankle X-ray in the ER, to really very complex sort of clinical care summaries to provide a provider to help them sort of work through a decision-making process with a patient. And then, sorry, what was your...
Patients' preferences.
Oh, yeah.
Their fear of statins.
Yeah, so I mean, there's some work that's being done by different investigators to really, try to couple interviewing patients and then patient education. The other area that comes to my mind is antibiotic prescribing in the ER for upper respiratory illness. And, and so that's a little bit out of scope from my focus, but I think there's a real need to help educate and support patients in informed decision making around that. So, thanks.
So it's a really good illustration of applied informatics work in the clinical context. I'm going to ask 2 questions. I suspect that I know the answer to the first one. Were these trials that were conducted in the, I forget the acronym, you have a lot of acronyms.
Yeah, I'm sorry.
In the Learning Health System Initiative that VUMSC has with VU?
Yeah, no, neither. Both were, the laboratories of both of them were the VA.
The VA, right. Okay, so that, that was obvious. But I think you alluded to how long you had worked on the first project. And, I'm thinking we talk more about rapid embedded clinical trials. If you think of what Cheryl Gatto leads at Vanderbilt, the idea is find a clinical question that the health system is interested in, and then do in 6 months or a year, do what you did in a much longer time. Mike Usher from University of Minnesota, who just joined us, he just gave a presentation this morning to our group about the same thing at the University of Minnesota in the Center for Learning Health Systems there. So what do you think is needed to make this more, agile, more responsive?
Yeah, it's a great question. And I think it's on a lot of healthcare organizations' minds about how to sort of rapidly bring in risk adjustment and risk stratification and deploy them in a system and maintain them. I think it takes infrastructure and governance and policy. So you need a committee that helps manage sort of the organizational workflow of these sorts of tools. You need partnership between business ownership by the clinical leaders. You need IT support, and you need infrastructure so that you can quickly bring it in and then deploy. And I mean, Epic has a lot of infrastructure to help do that. Cerner does too. So it's not so much, you know, a lot of this work was done over 10 or 15 years where some of this stuff didn't exist when some of this began. I think we're in a much better position now to be able to do some of those things. And I think even the monitoring, I think there's a much larger awareness of the community about the need to monitor these algorithms, but the scalability of doing that, right? You can imagine when you have 150 algorithms in play in your organization, if you don't have some sort of process to monitor them, and then if there's a problem, who do you go to even ask what to do? If you don't have a governance and a structure around that, it's hard to scale. It's a great question. Definitely one we're I think, trying to figure out.
Yeah, so I am a primary care physician too, and did work in the VA for about a decade. And so the question, two questions. One is, you know, you're working on trying to decrease the signal to noise ratio, you know, give them a reasonable number of alerts. But the two other things for primary care is, this was for statins. So you could imagine the number of other diseases and things that come in. So there has to be a way of prioritizing the number of conditions we give on alerts, as well as the number of alerts. That's one thing that has to be figured out. The second thing is thinking of a way to bring the patient into it, so that doesn't all have to go through the funnel of a 15-minute primary care visit. You know, messages are sent them to a portal. In other words, here's the 3 things we recommend based on our AI or something. But anyway, is there work being done in terms of trying to incorporate the patient into this and leaving the provider out?
Yeah, no, that's a great question. And, you know, these all, I mean, I think one of the delays of ACT is that you had to contact the patient in order to interact. So I think there is some work trying to use secure messaging portals to try to deliver messages directly to the patients. There's a little bit of complexity there, though, because if you start sending a bunch of things to patients about these different recommendations, then if it's unclear to the patients whether it's coming from an automated system or directly from the provider or the nurse or the PAC team or the primary care team, you get into complexities around appropriateness of that and whether the provider. So I think that's very important. We want to basically be able to do that. I think it's a little bit of an iterative process. You know, also the other side of that coin is the patient-generated outcomes, right? So there's a lot of patient public sort of, you know, Fitbit and other sort of, and the patients are all wanting their providers to manage and then interpret. So there's also going to be a wave, I think, of trying to use AI to help manage the inputs from the patient to help the provider more efficiently manage, help support the patient in their decision making. So it's a multiple channel. Very good question. Good to see
Michael,
you.
yes, you too. Thank you so much. This was an incredible talk. I think great example of using clinical informatics and data and really applying for action into practice. So thank you. I love the examples. I have a question, I guess, maybe 2 questions broadly, and then maybe more specifically around that first trial with AKI. So curious to what extent you work with implementation scientists, and I was thinking about I love that you have this data that you can't present, I know, here yet on the sustainability, but curious of, how, are you working with the implementation scientists on this to think about the sustainability aspects? So, it comes to mind that trial specifically, you have opportunities, I think, for, was this trial implemented as planned? Was it delivered as planned? Did you have better responses from some or pushback from some providers or units versus others? Are you learning from some of the best practices to inform future implementation? And then maybe along with that is that sustainability aspect. So how do you maintain this and continue this in practice beyond the length of the trial?
Yeah.
Thank you.
Yeah, those are great questions, and to the point. I will confess that each one of those examples could be a full hour talk, and so what I focused on the informatics a little bit more than I could have. So there's the Dartmouth, for the first trial, Dartmouth led the implementation science, and then we had a group at Vanderbilt and Dartmouth that did the qualitative analysis. So we have actually a qualitative assessment of what were the sort of key drivers for change in the system, and what facilitated the cath labs for making the policy changes, and how did they sustain them. And so that's a qualitative assessment that's seeking publication right now. And then there was a sustainability assessment as well. So we are using sort of mixed methods. And again, I'm being very clear, I'm the informatician, and so I always partner with an implementation science person on these things. Thank you.
Are there any online questions, Michelle? Okay. All right. Well, thanks, everyone. Please join me again in thanking Dr. Matheny for his fantastic presentation today.
Yeah. Thank you.